So now we're going to talk about the bipolar disorder, dissociative disorder, depressive disorder, and other psychotic disorder like schizophrenia. So the first one here, the bipolar, right? So in this PowerPoint, we are going to talk what is bipolar, or we are going to talk what are the nature of mania, hypomania, rapid cycling. We are going to talk about the type of bipolar, like bipolar 1, bipolar 2, then other psychothymic disorder, risk factor of bipolar. We should talk about the manic sign symptom, depressive sign symptom, and also the care of the patient. I mean, nursing care for our patient. So bipolar characterized by episode of mania and depression with the period of normal mood and activity in between. So bipolar patient, maybe 1 week they are manic mood, another week they are depressed. The medication we used for bipolar is called lithium, right? Lithium carbonate. And also it is a little bit important, so I'm sharing, but in pharmacology we will discuss more. Lithium has a very narrow therapeutic index. So when you give the lithium, you have to check the blood level of lithium because they causes the toxicity. Also, we have to check the electrolyte, especially the sodium level, because sodium precipitate the lithium toxicity. So lithium is a medication or drug of choice for bipolar disease, or it is the mood stabilizer. So about the lithium, so which can be toxic and therefore require the regular monitoring of serum lithium level to help keep the medication's therapeutic index level within the range. A stable intake of adequate dietary sodium and fluid may be maintained to avoid lithium toxicity. So sodium level is very important. When sodium level is less, so sodium or hyponatremia precipitate the lithium toxicity, right? Other medication we use for bipolar, it is called anti-anxiolytics, right? So as I told you, the patient who have a bipolar disorder, I said, they are mood disorder with recurrent episode of mania and depression. Behavior like mania, it is excessively elevated the mood, just opposite depression. Or the mania lasting more than 1 week usually require, if the mania lasting more than 1 week usually require hospitalization. Some of the patient present with hypomania. So hypomania, less severe form of mania, does not require hospitalization. Okay, And some of the patients have a rapid cycling, means more than 4 episodes of mania or hypomania within a year. All are the sign of bipolar disease. As I told you, the bipolar patient, they have maybe 1 week depressed, another week is manic. So usually the depressive patient, all are signs are negative, like they said, they feeling apathy or no pleasure in their life. They crying, they do not eat, they weight loss, fatigue. And manic patient, just opposite of depression, usually all are positive sign, like they are very impulsive, easily distracted, they're very energetic the time of manic phase. They always pleasure, look for the pleasure, right? Pleasure seeking, or they have a delusion sometime. So delusion means the false belief in mind, but not hallucination. Hallucination means false belief with sensory component. Maybe false belief with hearing or touching or smelling or feeling problem, right? So we will discuss more about them when we go for depressive disorder. So now here we are talking about the bipolar disease. So as I told you, the bipolar patient, sometime in some book, type of bipolar category according to the bipolar 1, bipolar 2, right? Or psychothymic disorder. Simply, I want to share with you, bipolar 1, basically at least one episode of mania, alternating with a major depression. Bipolar 2, once or more hypomanic episode, alternating with a major depression. So 1 week maybe mania, alternative week is depressed. Psychothymic disorder, basically 2 years of repeated hypomanic episode alternating with minor depression. What are the risk factors related to bipolar disease? One is the genetic or psychological stressor, neurological disorder, or substance use abuse disorder. So if anybody use the heroin, morphine, methadone for a long time, the chance of develop bipolar problem, right? So now go next here. So what are the intervention, right? So intervention about the manic phase, manic sign and symptoms, depressive sign and symptoms we will talk about, and also as a RN or LPN, what is our roles. So basically the manic patient, they are mood easily switching. The manic phase, patient feel restlessness, they fight of ideas, or they talk too much, or they feel grandiosity or grandiosity thinking or impulsiveness. They have a poor judgment, decrease the attention span, insomnia, neglect of their daily living activities, including even eating or drinking. They do not eat well, weight loss, and possible delusion or hallucination. So let me read it. Remove the hazard object when we give the service to them, right? So basically, okay, so I said the bipolar patient, sometimes patient has a manic phase and sometimes they are depressive phase. During the depression, usually patient feel angry or flat affect, they crying, they difficult to get concentration, possible risks for suicide, and also lack of grooming or hygiene and changing in the sleep or appetite. So all are the sign and symptom of bipolar disorder, but it depends upon, is it manic phase or is it depressive phase? Whatever it is, now we are going to talk about the intervention. Intervention for manic phase, right? Nursing care during the manic episode. So also we have to provide, we should provide the safe environment. So remove the hazard objects, protect the patient from poor judgment. So also decrease the stimulation, monitor the client closely for fatigue, provide the frequent rest period, provide the private room if possible, encouraging the client to ventilate feelings, use the claimed slow interaction, help the client focus on one topic during the conversation, ignore or distract the client from grandiose thinking. It's mean, if I say, I'm talking with the president, right few minutes ago, I tell how what he or she do. Or I said, uh, like one of the poets from England, his name is um, Shelley. I I said, oh, I just took one of the poem by that writer, and then I said, it's I wrote it, right? So it's always thinking too much high, grandiosity, no relation with realities. So when you give the care of them, we have to always keep in mind, provide safe environment, right? Also decrease the stimuli. And if patient has any suicidal ideation, try to one-to-one supervision, right? Or if patient are very aggressive, self-injurious, keep them restrained, may be necessary if the patient poses at the risk to self or others. Also provide the frequent rest period. Monitor the sleep because insomnia is most common. Also fluid and food intake important. Provide high calorie, provide high calories. Okay, so provide the high calorie food, or it's called high calorie finger foods. Supervise the client, supervise the client choice of clothing, reduce environmental stimuli, monitor for the sleep, right? And also self-limit or give the concise the explanation, use a claim approach. So avoid the competitive games, provide the gross motor activities such as yoga, walking, lead beat exercise, provide the structured activities. Also get involved with their daily living activities. Provide simple and simply direction or simple explanation, nothing complicated. So also provide the medication. As I told you, lithium is a drug of choice, or anticonvulsant, antipsychotic medication, anti-anxiety medication, anti-depressive medication. This is the medication we have to give to the patient when we deal with them, right? Now we are going to talk about the depressive disorder. Depressive disorder, I said. Depressive disorder, if the patient are depressed, what we have to do or what we should do and what are the care or intervention we have to provide for them, right? And also in depressive disorder, we should talk about the risk factors, sign symptom, and also the type of depressive disorder, right? So first of all, let me read it. So depression affects the feelings, thoughts, and behaviors. It can occur after a loss or include the loss of self-esteem, the end of a significant relationship, and the death of a loved one. So if you have any setful apathic incidents in your life, this is called traumatic events that act as a trigger and your disease start. The loss of followed by the grief. If this process does not resolve, the depression should be resolved. Depression may be mild, moderate, or severe. The treatment include the counseling, antidepressant medication, and ECT. ECT stands for electroconvulsion therapies. ECT stands for electroconvulsion therapies, right? So the risk factor for the depression, as I told you, maybe sometimes family history, or usually female is attacked more than man between 15 to 40 years of old, and patient over 65, men or female, both are equally affected. Even sometimes patient has a medical illness, like patient is diagnosed by chronic disease, they chance to go under depression, or negative life events, substance use or substance use disorder or substance abuser, or even if you are single in your life, the chance of develop depression. So whatever the type of depression, mild, moderate, or severe, the common sign symptom of depressive patient, they are they have anorexia, fatigue, flat facial expression, poor grooming or hygiene, also slow the thinking or slow to speech, also some psychomotor change, right? Psychomotor change, I said. And but there are if the patient has a major depression, like major depressive disorder, this is really bad. Or sometimes some of the patient has a seasonal affect disorder. So all year they're good, but they are during the winter or particular time they are undergo to the depression, or sometimes they're dysthymic disorder or premenstrual dysphoric disorder also. So whatever the major depressive disorder, this is the most important. And when we should talk or call the patient as a major depressive disorder. So let's go here, mild depression. What are the signs, symptoms? We combinedly tell you already. Patient is mild depression triggered by external events, feeling sad, feeling let down, mild alteration, irritabilities, increase or decrease the appetite, increase use of alcohol, moderate. Moderate depression persists over the time. The person experiencing a sense of change and often look for the help. So dependency develop, right? Low self-esteem, feel helplessness, powerlessness, right? Also their mood is varies with the time or day. Slow thinking process, right? And moderate depression, especially negative thinking. They have a suicidal ideation. So when you take the history, you have to exclude, you have to explore, you have to find out the patient has any suicidal history or not. If they have suicidal history, make sure one to one observation, sleep disturbance, social withdrawal. They like to isolate it. They do not go for the any party, right? In social talk. Anorexia, weight loss, because appetite reduce, do not eat, do not drink. They feel fatigue. Also, menstruation change, increase the use of alcohols. So major depressive disorder, this is super important, and I'm going to give focus about major depressive disorder. Usually the major depressive disorder occur every day for more than 2 weeks with 5 or more of the following symptoms, like depressive mode, more than 2 weeks, I said, has to continue. Depressive mode, insomnia, excess sleepy, difficulty of concentration, or suicidal ideation, weight gain or weight loss. Weight gain or weight loss more than 5% over 1 month, or psychomotor increase or decrease. So the major depressive disorder, the sign symptom I told you, but what you need, the symptom more than 2 weeks within 5 or more of the 5 or more of the following symptoms. Following symptoms means this is the symptoms. from here to here. So now go for about the major depressive disorder, continue, then we go for intervention, how we have to take care of them. Okay, so first of all, if patient come to you the acute phase, right? So acute phase, severe psychomotor alteration is also sign symptom of major depressive disorder. Anorexia means decrease the appetite. If they do not eat, if they anorexia, definitely weight should be lost. They do not eat, so constipation is very common. Urinary retention developed because of negligence, lack of sexual interest, terminal insomnia, or delusion and hallucination. As I told you, what is delusion? False belief, right? What is hallucination? False belief with sensory component. Sensory component may be hearing, maybe touching, maybe smell, or feelings, right? So all are present in major depressive disorder. So acute phase usually, or patient have a severe clinical sign of depression are present. Usually patient give history of 6 to 12 weeks in duration, possible need, if sometimes patient need the hospitalization. Because the depressive disorder, patient greatest risk for suicide during this phase, in acute phase. So they need one-to-one observation. So major depressive disorder, the goal of treatment are, or the goal of the intervention, treat and reduce the depressive manifestation. Also, if the patient has a continuation of the phase, so increase the ability to to function, or 4 to 9 months in duration, right? And another phase called maintenance phase. What is the remission, basically? So now go for intervention. What are the most important for us for our exam, right? So intervention, basically, first of all, the priorities is very important, and I said we have to find out their suicidal ideation or not, right? If they suicidal, one-to-one observation, this is the intervention. So whatever, when patient come with the depressive disorder or major depressive disorder, always assess the patient for suicidal risks and implement one-to-one observation. So again and again, I'm repeating same things because this is super important for our exam. If the patient are depressive, it is good. No, not allow for private room. Why? Because due to the risks of self-harm, or also communicate with simple sentence. Simple sentence. When you communicate with them, simple sentence. Allow the extra time for the response. Okay, because they slowing the thinking, because the patient are go for the slow of thinking. right? So what I write on the bottom, for a client at the risk of self-harm, ask the client to directly, have you thought of hunting yourself? Or directly ask them, have you tried for suicide any time? Right? So in psychiatry pharmacology, I will discuss about the um, depressive medication, but basically just keep in mind we have to provide medicine as prescribed. Basically, healthcare provider give them SSRI, selective serotonin reuptake inhibitor, or they give antidepressant like tricyclic antidepressant, or MAO, means monoamine oxide inhibitor, or atypical antidepressant. The patient, again, before to go next disease, the patient with suicidal ideation, there is the increase the energy to carry out a plan after a week of treatment. Okay, so just we are going to talk about the schizophrenia, whatever you like you ask. So what it is, the schizophrenia is a group of mental disorder characterized by psychotic feature like hallucination and delusion, disordered thoughts process, and disrupted interprofessional relationship, disturbance in affect, mood, behavior, or thought process. Treatment with medication, control the symptom, right? So data collection means what are the signs and symptoms of the disease. So schizophrenia, basically, this is the psychotic disorder, right? Psychotic disorder. Basically, the psychotic thinking or behavioral problem. Psychotic thinking or behavior for more than 6 months. Usually patient give the history more than 6 months, and also functioning or relationship significantly impaired. The patient who have the schizophrenia, their function, daily activities, their jobs, also relationship is significantly impaired, right? And here I said the patient present with some of the sign of the symptom, right? And this is which said like appearance problem, look like they are uh, psychotic patient, or alteration of the speech, may neglect themselves or neglect the hygiene, eating, sleeping, or neglect elimination, body image distortion, maybe preoccupied with somatic complaint. So the some of the patient present with you, some of the patient present with you with the positive symptoms, we said. Some of the patient present with the negative symptoms. Okay, and here we supposed to go and explain different way of schizophrenia, but here we going analysis the data, easy way to explain. Some of the patient present with positive symptom and some of the patient present with negative symptom, but we have to know what it is, right? What is positive symptom, what is negative symptom basically. But before to go positive and negative symptom, keep in mind the schizophrenia are psychotic disorder, right? Psychotic disorder, you know that. The psychotic means they have or they does not in relation with reality. They have false belief, and that is called delusion, or they have a false belief with sensory component. It is called hallucination. Some of the patient making a new word, and this is called neologism. Some of the patient also have repeatedly same thing or same talk, same word used over and over, right? Over and over again. And that one is called echolalia. Some of the patient are fight of ideas, and this is called jumping the topic to topic. Even when patient present a negative symptom, this is all actually positive sign. And negative symptom basically patient are maybe mute, they does not talk, they have a catatonic behavior or homicidal thinking, suicidal thinking, or withdraw thinking. This is negative. Or stupor, muscle rigidity. So catatonic behavior is common. Catatonic means inability to move normally. So here I'm going to read from here. So catatonic posture, first of all, the catatonic posture, it is actually negative behavior. Catatonic excitement, negative, right? So I want to recap it. The positive symptom usually present of things not normally present. As I told you, hallucination is a positive symptom. Delusion is a positive symptom for schizophrenic patient. Delusion means false and fixed belief. What they believe, this is false. No relation with reality, but they believe it, and that belief is fixed, right? And they have a strange motor movement. They have a speech alteration or agitation. Negative symptom, one are the said negative symptom are absence of things that are normally present. So usually affect or flat affect or allogia, decrease the thought or speech, or they have a lack of energy. This is a negative symptom, or lack of pleasure, right? Or lack of motivation. Lack of motivation. All are negative symptoms, right? So catatonic excitement or catatonic posture is the also one of the most common problem of schizophrenic patient. What is catatonic posture? Right? Catatonic posturing means inability to move normally, right? Catatonic, holding the bizarre posture for a long period, moving excitedly with no environmental stimuli, possibly total immobilize, inability to respond to comments, and repetitive or stereotype movement, motor activity that may be increased as evidenced by agitation, possible inability to initiate the activities. Emotional characteristics, sometimes mistrust, view of the world as threatened or unsafe. Affect may be blunted or may display the feelings of helplessness, anxiety, guilty, depression, and also they have a compulsive rituals or over complaints. What the others? Alternative thoughts process, right? Impaired the reality, fragmentation of thoughts, thoughts blockings. So what the false belief, they will be fixed upon that. Loss of association, they have a echolalia, they have a neologism, and they have a musical thinking. What is echolalia? Means they make a new word that you do not find in the dictionary. Or neologism means echolalia means repeated same things over and over is echolalia. Neologism means making a new words, and also they have a fight of ideas, so they jumping one topic to others, they change the subject, and they have also musical thinking, right? So now go here, the type of delusion. So I said the false belief, right? So basically delusion sometime persecution or delusion of grandeur or somatic delusion, right? This is defined delusion disorder. And also go here, the another data is called perceptual distortion, illusion that may be brief experience with a misinterpretation or hallucination, right? Hallucination basically, and hallucination is five sense, such as any hallucination about the object, hallucination about the sensation or image with no bias in realities, right? So hallucination, I said, the sensory perception that do not have any external stimuli. Type of hallucination, sometimes auditory. So patient hear the voice or the sound. Patient hear the voice or sound, or the patient has a patient sometime hear some comments. Maybe they said God talking to them. They hear something. Voice instruct the patient to perform, do that, do this, right? Perform the action at the risk to harm the self or others. Visual hallucination, one, visual means patient see the person or things what other people do not see. Olfactory hallucination means patient smells some odor, but you do not smell it. But this odor is called olfactory. Some hallucination are tactile, means patient feel body sensation, right? So this is the type of hallucination. If you know, this is good. And now, but basic things or most important for us are the care of the patient, right? Care of the patient, and this is called intervention, right? Intervention. So intervention, when patient has active hallucination, what we have to do, monitor for hallucination, then intervene with one-to-one contact, decrease the stimuli, or avoid the conveying to the client that others are also experiencing the hallucination, and response verbally to anything real that the client talk about. Also avoid that touching the client. Don't touch them, right? Because you do not know what type of hallucination they have at the beginning, right? As I told you, some of the patient has a hallucination, abnormal feel the body sensation. So if you touch them, they may be thought you are doing something harmful for them. Also encourage the client to express their feelings. During hallucination, attempt to engage the client attention thoughts, accept and do not jokes what they are thinking, what they share with you. You have to be sincere and active listener. Provide easy activities. Monitor the sign of increasing the fear, anxiety, and agitation. Decrease the stimuli, right? And admin medication is prescribed. And also for the client with hallucination, safety is the first priorities, right? So what are the nursing intervention? In a short, provide the safety is the most priorities. If patient, schizophrenia patient, if they have a delusion, interact based on realities, encourage the client to express their feelings, allow them to verbalize their feelings. Do not dispute the client or try to convince the client that delusion are false. Don't do this. And also initiate the activity on one-to-one basis. Alter the hospital routine as necessary, such as using canned or packaged food, recognized accomplishment or provide positive feedback for the succeed. So in a short summary, so what are the nursing intervention about the psychotic disorder patient? So we have to provide the safe environment or structured environment, right? Attempt to identify and reduce the symptoms trigger what increase the disease. We have to reduce it. Decrease the environmental or external stimuli. The priority, ask the patient directly about hallucination. Also include the comments hallucination, provide for safety for the patient, and also do not argue or do not agree with hallucination or delusion. So patients say, I saw a snake over the wall or big spider over the wall, but you do not see that. So you do not directly argue or disagree with them, or you do not agree with them, right? Better to give them significance than explain what it is. So as an example, I said, if they said, if patients say, I am hearing some voice, you do not say, I do not hear anything directly. You should different way. But I said, I do not hear anything, but let me check it. But it must be scary to hear the voice. Always, after all of this, we go for medication, right? So basically, we use atypical antipsychotic for schizophrenia.